another CME on this Tuesday evening. Thank you so much for joining in. I'm Dr. Umayal Murugesan, President of Kanchipuram Obs and Gynec Society. And actually, I'm contesting for the chairperson for Violence Against Doctors Committee. So thank you so much for all logging in for this two great talks, which you are going to listen in a short time from now. I would like to introduce our conveners. We have got three more conveners. Dr. V. Ramalakshmi. Madam is a zonal coordinator for NTRS AP. She's a professor in the Department of OB-GYN in Mandya and Secretary Kurnool OB Society. And she is contesting for the Foxy's
Education and Research
Education and Research Committee. Welcome, Madam. And Dr. Vijaya, she's HOD and Professor of ESI Medical College in Chennai, and former professor and HOD of IOG again Chennai. And she has a lot of teaching experience with her. And Madam is standing for Madam, your
Medical Education
Committee. Okay. Next convener is Dr. Shweta Jha Kaul. She is the director of Niramai Care Center of Indore, and she's got a lot of awards and affiliations. And she is actually standing for the committee of
Modern Technology in OB-GYN Committee.
OB-GYN. So four contestants are actually here as conveners. So we would, Madam, I would request Dr. Ramalakshmi to take over and introduce Alpesh, who is going to be our chief guest for this today's event. Radha?
Hello. Am I audible?
Yeah, audible.
Yes, very much.
Dr. Alpeshar CV, I want.
Sahiti?
Alpesh has been a wonderful supporter for all of us, ordinary OB-GYNs across India. He's been a great inspirator. And his work...
Shall I introduce Alpesh, sir?
Yeah.
Sir is called as father of digital OB-GYN in India, and he has been conferred FRCOG by RCOG, main source person for many national guidelines for Government of India and the country, pioneer for the concept and establishment of Obstetric HDU in India, and the first guidelines on COVID-19 in South Asian countries, conducted many community connect programs on different preventable women health issues, worked a lot for curriculum, including publishing Foxy's first textbook for PGs, preparing logbook UG and PG, has been awarded as Abdul Kalam Living Legend Award, has been honored as one of the 7 legends across the world for cervical cancer prevention by IFCP. Recently awarded oration of 45 minutes in FIGO World Congress, awarded 47 orations. Welcome, Alpesh sir. It is my pleasure to introduce as the chief guest to this program.
I would like to just say one word about sir. He was the president Foxy during the COVID period.
Yes.
So, and he used that time so wisely. We could not travel, and he used the online media as a big thing, and he made sure that whatever information has to go from the Foxy reaches every Foxian through the online media. So he was a great supporter of digital media, and that which was very well appreciated by everyone across. Over to you, sir. We need your few words.
Alpesh.
Thank you so much for the kind words and appreciation. Thank you for giving me this opportunity and inviting me for this honor. A very good evening to all of you, and my high regards to chief guest Dr. Rajendra Singh Pardesi, Dr. Kiran Kurkorti, my dear brother Dr. Ajay Mane, respected Dr. Durga Das, President Kashoga, and all the faculties and delegates. I'm so happy to see that 4 states are joining for one academic activity. It is very good that all of us join for some good cause, for some good purpose, some good academic and social and fellowship activities. So I would like to congratulate President Secretaries of all the societies, Andhra Pradesh, Tamilnadu, Madhya Pradesh, Maharashtra, Obstetric and Gynecological societies. I know each one of you, all the conveners, 4 conveners, Dr. Umayal, Dr. Radha Lakshmi, Dr. Vijaya, and Dr. Sweta, since long, and I have seen all of them working very hard in different organizations or at their home society or in their states or at some programs in Foxy level. Since long, they all are working very hard, and I also excited to see all of them contesting for Foxy elections, and I wish all of them best of luck. We wish to see all of you working as well for the benefit of Foxians at Foxy. Today we have selected two very good topic for the webinar, Doppler in obstetric, which is actually a very big topic, very wide topic. It covers a lot of, we can say, many topics in one topics in this topic. And we have very, we can say, one of the authority for this, as a speaker for this topic,
Sujit.
Dr. Sujit Konkar. And I'm sure the lecture is going to, the talk is going to be very much useful to all the delegates. So many things to be learned, and it is always important to update ourselves for such an important topic. Second topic is very important, and we can say it's a life-saving surgical skill on obstetric hysterectomy, and we have very eminent, very senior faculty for this, Dr. J.M. Kannan. We all know her since long, and I'm sure that our delegates will be benefited a lot. It will be very much helpful in our routine day-to-day practice to save lives of many mothers. My best wishes for the success of this webinar, and I wish you all please continue such activities regularly. Thank you very much once again. Thank you.
Thank you, sir.
Thank you, sir, for your wishes.
Thank you, sir.
And your blessings. Next, I would like to introduce one more doyen from India, Dr. Rajendra Singh Pardesi, a great Maharashtrian and a great.
It's okay, Umayal. It's okay.
Sir,
So,
something, sir, please, sir.
sir, it is our pleasure to introduce you,
Yes, sir.
sir.
Let everybody know, sir, because that is how we get to know each other. So, sir is a consultant at Jijai Maternity and Nursing Home from Sambalji Nagar, Maharashtra. He's affiliated to so many societies, so Foxy, IME, IFU, MBSFM, IMS, SOFC, IAG, everything, and Aurangabad OB-GYN Society. He has presented so many papers, around 28 in national and international forums, and he has got so many awards, 7 best paper awards in Foxy and ACOG conferences. Has been a faculty of ACOG to 2011 in various countries like Taipei and Bangkok, and also in Kuala Lumpur and Figo. Has been the chairperson of Food and Drugs Committee of the Foxy and has been awarded Hansotia Best Committee Award, and was the VP of the Foxy between 2019 to 20 and VP of AMOX 20 and 22. And right now he is the president of AMOX 22 to 24. Sir, welcome you, sir. And you have.
So one word I want to tell, sir is a down-to-earth person and is easily approachable to everyone. And he is of very friendly nature. He gives his help to everyone, whoever asks his help. Thank you so much, sir.
thank you, Dr. Umayal. Thank you, Dr. Radha Lakshmi. Good afternoon, everybody. Respected Chief Guest, Dr. Kiran Kurtakoti, sir, Dr. Alpesh Gandhi, sir, Guest of Honors, Dr. Durgadas Asrana, and Dr. Mane, sir. I am feeling proud and honored to be a part of this program arranged by MP, Tamil Nadu, Andhra Pradesh, and Maharashtra combinedly. And first, I wish to congratulate conveners Dr. Umail, Dr. Radha Lakshmi, Dr. Vijaya, Dr. Shweta Kaulja for organizing such an academic feast on Doppler in obstetrics and obstetric hysterectomy. As Dr. Alpesh told, these two topics are really important and they will save the mother's life. And ultimately, we can reduce maternal mortality also. Nowadays, Doppler is an integral part of every obstetrician, and Dr. Sujit Konkar, I think he's the right person for this talk. He's also contesting for the post of Genetic and Fetal Medicine Committee for FOXI. Obstetric hysterectomy is mainly an emergency procedure to save life of mother. Dr. Kannan, madam, is right person for this talk. With the eminent faculties and experts and chairpersons, I think this is going to be a great event. I wish every success to Dr. Umail, Dr. Radha Lakshmi, Dr. Vijaya, Dr. Shweta Kaulja, and Dr. Sujit Kondkar for their future endeavor in FOXI as chairpersons.
Thank you, sir.
Wishing every success to this webinar. Thank you. Thank you so much for inviting me. Thank you.
Thank you, sir.
Thank you, sir. Thank you. Thank you.
So the next chief guest is
Dr. Ajay Mani, sir.
you are introducing Dr. Ajay.
Yeah. Sir is a member.
Keep this. Hello.
Good evening, Ajay Mani, sir.
Radha ma'am, we'll
yes,
skip
sir.
this. We'll skip this.
No, sir, just few words.
Two lines.
Sir is a member of NIMC, Medical Legal Consultant since 18 years, Chairperson, Sexual Medicine Committee, FOXI, Chairperson, Official OMOX website, Chairperson, Adolescent Health Education Committee, OMOX 2012 and 14, past President, Aurangabad Obgyn Society, and 9 publications at national and international level, and ex-superintendent MGM Medical College, Aurangabad, Health Advisor, Sport Authority of India, and President Rotary Club of Aurangabad, and he is the Vice President of FOXI 2024. So welcome Ajay Mane sir, and I request you tell the few words of your wisdom, sir.
Yeah, thank you.
Welcome, sir.
Ma'am. Thank you very much. Respected Alpesh Bhai, our elder brother, Dr. Rajan Singh Parthi sir, who is my mentor, and Dr. Kiran Kurtukoti, who is the president of Maharashtra Obstetric Society, who is our elder brother again, and respected Durga Das sir, who is the president Kasoga. And I appreciate the efforts of all the conveners, Dr. Umail ma'am, Dr. Radha ma'am, Dr. Vijaya ma'am, and Shweta. So because you have collected a galaxy of the experts and galaxy of the stalwarts from almost all over India for these two topics. And these two topics are very much important in the field of obstetrics and gynecology. Doppler in obstetrics, which will be taken by Sujit Konkar, who is my classmate and my friend since childhood. And he is the best teacher in Maharashtra for the Doppler studies. He usually conducts lecture. He is having his own FOXI recognized center, and he is conducting regular the teaching classes, and he is accepting the students from all over India. He is the best teacher. You will realize that after listening him. So best luck, Sujit. And the second topic will be obstetrics hysterectomy, which is again a very important topic for all of us, because in day-to-day obstetrics, we never know which patient will go in that position and which patient will come out. So we must know all the small things which is needed for the obstetric hysterectomy. I appreciate all the chairpersons. I must endorse the names: Dr. Jyotiji, Dr. M. Chandra, then Dr. Isri Devi, Dr. Rekha Rajesh, Dr. Uma Devi, Dr. Rakhi Dr. Gayatri ji, Dr. Padma ji, Dr. Anju, and Dr. Purnima. And for the second topic for obstetric hysterectomy, the best teacher in the India, that is J.M. Kannan madam. So we are very, she is the senior most, I am the junior most, and we are friends since 18 years. So I have seen her working for so many years. We have worked together also. She is the best teacher for obstetrics, and she is a typical teacher. She will teach you everything. So I appreciate the efforts of all the conveners for this, and I express all the best for all endeavors in FOXI. All my 3 friends, So thank you very much for calling me here and giving me the honor. Thank you very much, and best luck for this webinar.
Thank you, sir.
Yeah.
So, Umayul,
Thank you,
Durgadas Asarana,
Yeah,
sir.
please send Durgadas. Dr. Durgadas sir is the president of Kasoka. And thank you so much for joining, sir. He is a member of IMS and a member of ISOPAP, and he has been the past president of Tumkur Obstetrics and Gynaecological Society, and is currently the associate professor in Sri Siddharth Medical College, Tumkur, and also a consultant in the Kasturba Hospital. So we welcome you, sir. Thank you so much for joining in, and we would like few words of wisdom from you, sir.
Good evening, everybody. At the outset, I thank the four conveners for giving this opportunity to be a part of this program. Dr. Umayal Murugesh, Dr. Vijaya, Dr. Radhalakshmi, and Dr. Shweta Kaul. I feel very much honored to share the dais with the great stalwarts of today evening, Dr. Alpesh Gandhi sir, my dear Rajendra Singh Pardesi, Kiran Kurtikot, Dr. Ajay Mane, a very good friend. You have to, it is a beautiful combination of the four states, and you have chosen the very good topics. Both the topics are very essential for an obstetrician, the Doppler in obstetrics and obstetric hysterectomy. Not only you have taken the very good speakers, as rightly told Dr. Sujit and Dr. Jamkandan madam, even the experts.
Sir, you got muted.
Sir, you are muted, sir.
Sir, unmute.
Yes. The experts of today evening, Dr. Jyoti Chandran, Dr. Chandrapurnaswamy, and the experts of another talk, Dr. Raki and Dr. Gayatri Professor, and the chairpersons of today, Dr. Sridevi, my dear Dr. Rekha and Dr. Uma Devi, Dr. Padma Shukla, Dr. Anju Verma, and Dr. Purnima Sharavana. It is both the topics are very relevant, especially the obstetric Dopplers. It's such a vast topic, and nowadays it is the third stethoscope of a obstetrician. Each one should know about the scan and the Doppler to address his obstetric practice, and of course, obstetric hysterectomy, the life-saving procedure. With these few words, I want to tell all the best to all the consultants, my dear Dr. Umaya Murugesh, Dr. Radhalakshmi, Dr. Sujit, a special, and Dr. Vijaya, Dr. Shweta Kaur, and to Dr. Chandra Punnaswamy for her ICOG contestant.
Thank you.
All the best to everybody. Thank you. Thanks for the opportunity.
Thank you,
Thank you, sir.
for warm wishes. And I would like to extend the warm, sir. Tell me, sir, Ajay Mane, sir. You wanted to say something, Ajay Mane, sir?
Yeah. We all are with you, all
Thank
candidates.
you so much, sir.
Yeah,
Thank you, sir.
100% you are winner.
Thank you,
I would
sir.
also like to extend a warm welcome to all the chairpersons and the experts. So Dr. Jyoti Madam, Dr. Chandra Madam, Dr. Sridevi, Dr. Rekha Rajesh, my dear Rekha Rajesh.
Let me introduce Jyoti Chauhan, madam.
1 second, madam. I will, and also Dr. Raki Bajpai, Gayatri Madam from Madurai, Padma Shukla, Dr. Anju Verma, and Dr. Purnima from E-Road. So welcome you all for this wonderful CME, and thank you for joining in. Madam, please take it forward.
So, Jyoti. Jyoti madam did MS FICOG, President, Sagar Obstetric Gynaec Society, ex-regional director, Sagar Division. And she was the president of Students Union of JLN Medical College, Ashmere. Wow. Was adjusted best all-round student in JLN Medical College, did MBBS with 5 gold medals and MS in obstetric gynecology from JLN Medical College, Ashmere, and secured first position in university. And married to Dr. Pradeep Singh Chauhan and settled in Sagar, Madhya Pradesh, held various posts in government of Madhya Pradesh, and has presented multiple papers, various national and international conferences, fellow of International College of Maternal and Child Health, secretary of Sagar branch of Obstetric and Gynecology, and was awarded Nath Karni Trophy for best activities in the rural obstetrics, President Foxy Sagar. Jyoti guided her team to bag four medals. She was only doctor selected to represent in India in International Cancer Conference held at Lusaka, Zambia. Welcome, Chauhan Madam, Jyoti Chauhan Madam. Next our expert is Chandra Ponnaswamy Madam. She did her UG and PG Government Stanley Medical College, Chennai, and she is the gold medalist. Started first laparoscopic and IVF center of her district, Namakkal. Delivered first IVF baby and ICSI baby of her district, and she is a Foxy member since 1982, life member of various societies, founder president of Namakkal Women's Doctors Association and Namakkal OBG Society, faculty in many national conferences, and Best Doctor Award, Best Woman Achiever Award, Best Fertility Consultant Award, ISAR Dronacharya Award 2023. I welcome Chandra Ponnaswamy Madam, and she is having vast experience in OBG, nearly more than 40 years, and all the best for your future endeavor in ICOG elections, Madam. And I request Umayal to introduce Sridevi.
Yes, ma'am. Yes, madam. Madam Jaya, madam, welcome, madam. Welcome. Thank you for joining in. I know you are very busy in Oxy delivering a lecture there. Thank you so much for joining, madam, for the CME. I would like to now introduce the chairpersons for this, Dr. Sridevi, who is the Associate Professor of GMC Ongole Medical College, and she has been an UG of Cornell Medical College and post-graduation at Tirupati, and she has been a gold medalist, and she has been awarded the Best Doctor Award 2 times from the District Collector, and she has been trained in Harvard, and she has done a diploma in diabetic management, and is as a member of MEU. Welcome, we welcome you, madam. And Dr.
Madam, good evening, madam. Thank you, madam.
Good evening. And Dr. Rekha Rajesh, she is a stalwart from Hosur, and she is a clinical director of Vijay Shrishti Fertility Center, Hosur, and Krishnagiri, and Tirupatur, and director of Marthuva Fertility Center of Tirupati and Nellore. Matrutva. And she has a diploma of reproductive medicine in Germany, PG diploma in reproductive medicine, certified high-risk pregnancy specialist, a life member of ISAR, ASRM, IMS, PCOS, and IAGE, honorary president of Obstetric and Gynaecological Society of Krishnagiri Society, and advanced healthcare management. She's been certified. So welcome you, Rekha, for having joined in spite of your busy thing. And
thank you, madam.
And Dr.
Rekha, you are not visible.
Yes, ma'am.
Dr. Uma Devi is the next chairperson. She is the undergraduate from SVMC Tirupati, a gold medalist.
Who's calling you?
Postgraduate from SVMC Tirupati. She is the secretary of Tirupati Obstetrics and Gynaecological Society and is the assistant professor of Department of OB-GYN of Maternity Hospital, Tirupati. So welcome you, Uma, for this conference. And now
I request Rekha to introduce Sujit. Rekha, are you there? So I'll introduce Sujit. Sujit is my best friend. Rekha is there. Rekha.
Yeah. Good evening, everybody. And it's a privilege to introduce Dr. Sujit, and I wish him all the best for the forthcoming elections. Sir is an MD OBGYN at GMC Aurangabad. He's had his ultrasound training at Bimal Sahani and Sonoscan Center. Basic invasive procedure training with Dr. Khurana sir at Apex Institute of Fetal Medicine and Reproductive Sciences. He's FMF certified for 11 to 13 weeks scan and PE screening Doppler. Vice President, Society of Fetal Medicine, Marthwada Chapter. Past Chairperson, Fetal Medicine Committee. Amox, member of ISOG, Director, Sri Hospital Foxy Recognized Ultrasound Training Center, and interested in advanced fetal ultrasound and fetal intervention. Welcome, sir.
Thank you. Thank you for nice introduction. Now, I will share my screen. Am I audible?
Yes, sir. Very much. Yes, sir.
So, one word about Sujit. He's a good friend of mine. Whenever I ask for any webinar, he never says no. So whoever want to know anything about fetal medicine, you can call him.
Thank you. Thank you for those kind words, ma'am. Let's start. Good evening, respected seniors, dear friends, and my colleagues. At the outset, I would like to thank conveners of this program for this webinar, Dr. Umayal ma'am, Dr. Radha Lakshmi ma'am, Dr. Vijay ma'am, and Dr. Shweta Kolja ma'am for this opportunity. So my topic is Doppler in obstetrics, which is very, very important basic topic and a day-to-day topic in our practice. Doppler is the language of fetus to communicate with the clinician about its problems. So what is the clinical utility of obstetric Doppler? In first trimester, we look at ductus venosus and tricuspid flow as a part of aneuploidy screening. We look at uterine artery as a part of prediction of preeclampsia and fetal growth restriction. In second and third trimester, we look at umbilical artery, MCA, ductus venosus, and uterine artery as a part of diagnosis and management of fetal growth restriction. Specifically, we look at MCA PSV as a non-invasive method for detection of fetal anemia. In any trimester, we look at fetal heart, whether it is normal or abnormal, with the help of color. Whenever there is any abnormal mass or cystic lesion in any trimester, it helps to say whether it is vascular or avascular. And anomalies of placenta and cord, they are nicely depicted when we put in color. These are the ISOC practice guidelines updated in 2021. Use of Doppler velocimeter in obstetrics. All obstetricians should undergo these guidelines because they are very, very important and basic guidelines. Now, coming to safety issues, ultrasound is safe, transvaginal scanning is safe, transvaginal Doppler is safe, 3D Doppler is safe, but spectral Doppler is questionable. So it is safe after 10 weeks, before 10 weeks. So whenever you need to measure fetal heart rate before 10 weeks, always use M mode and don't use spectral Doppler. This is the ladder of safety in Doppler cases. Now, what are the basic differences between all these modalities? Continuous phase Doppler is continuously emitting the signals and getting the signals. It is a non-invasive method of Doppler, and the best example is the bedside fetal heart rate monitor, which we use in our routine clinical practice. In color flow mapping, the Doppler signals are converted into various colors. Spectral Doppler is most important. It objectifies the things. It gives values and ratios, and this is the most common Doppler used in our obstetric practice. And power Doppler is non-directional Doppler. It is mainly used for slow flows. Now, basics of Doppler. What are we assessing? For that matter, you take any vessel, there are two components, S and D, that is systolic and diastolic component. Systolic component tells about the cardiac pump, that is how what is the pressure in the cardiac pump, and diastole tells you about the end organ pressure. This is the basic of any Doppler. Now, this is my lecture outline. The principles: uterine artery Doppler, umbilical artery Doppler, MCA Doppler, ductus venosus, and aortic isthmus. So Doppler effect is the change in frequency of sound due to relative motion of source and receiver. All of us might have experienced this, the sound of vehicle coming to you from far, approaching you and going away from you is very, very different. Same methodology is applied to these Dopplers. And again here, change in frequency is produced by moving reflector. In the first image, the reflector is stationary. In second image, the reflector is going towards the source, and in third image, the reflector is going away from source. You can see the change in frequency of all these three images. Now, coming to the equation of Doppler shift. This is a complicated equation. Most of us are not very much good in our mathematics. We don't like mathematics, but just important. Remember this cos theta. Remember that cos 90 means maximum Doppler shift and cos 0 means minimum Doppler shift. The importance of this slide is that whenever you are insonating any vessel, don't make angle of 90 degree. Always use degree of angle of 0 degree in alignment with the vessel. That will give maximum Doppler shift. Next is ultrasound beam angle and the movement what you get. When the flow is towards the probe, you get positive deflection like this. And when flow is away from the probe, you get negative deflection. This is basic. Now coming to angles and ratios. For absolute velocities, you need angle 0, but very few times in obstetrics we need absolute velocities. For example, for detection of fetal anemia, we measure the PSV of middle cerebral artery. In those cases, the angle should be perfectly 0, but for all ratios, all the ratios, they are angle independent. Then what does the color board tells you? It is the velocity scale. It is the range of mean velocities displayed. Flow towards transducers is depicted by red color. Flow away from transducers is depicted by blue color. light colors are depicted by high velocities and low velocities are depicted by dark colors. Remember that these colors don't tell you about whether it is artery or vein. It just tells about the flow of direction. Now, what are the basic optimum settings? In short, PRF, gain, filter, balance, gate size, and movement. Now, we'll cover shortly in one by one. When we open your machine, start the Doppler studies, you get on left-hand side this bar, and on right-hand side these numerological statues. So coming first with the velocity scale or PRF and aliasing. So this is set. For example, this patient is set at the velocity of 48 centimeters per second. Any velocity, any setting is written in this here. This means that this setting can detect the velocity up to 48 centimeters per second. So when we start examination, the low velocities are depicted by dark color, light velocities tell you high color, and when if the velocity is more than 48 centimeters per second, then the color shown is blue. So that it is important to remember that the velocity, the setting of this velocity depends on which vessel you are insunating. For example, the velocity of uterine artery is more than 60 centimeters per second. So with this setting is not good for uterine artery, because after 48 centimeters per second, there will be chaotic field on your screen. So this should be set for higher level. Next is filter. The area between these two bars is filter. You require high filter when we are looking at fetal heart, and it minimizes the disturbances from wall of the arteries. But in obstetrics, we usually have low filter. Next is balance. This green line is balance. It is the balance between grayscale and your Doppler, color Doppler. You need to have a good balance to better visualization of the things. Then gain. This is the gain on the right side. High gain will give you bleeding images. The blood is coming out of the ventricles, out of the image, flowing freely. So you should have a proper lesser gain for optimal imaging. Now, what are the various indices? All of us know resistivity index, pulsatility index, and SD ratio. But in our routinely practice, we use only pulsatility index. Why? Because it shows linear correlation with vascular resistance, and it does not reach infinity even when the diastolic flow is 0. And only other parameter used is the peak systolic velocity of MCA for fetal anemia. So for all purposes, for all other reasons, for all examinations of Doppler, we use only pulsatility index. Forget about RI and SD ratio. Now this is the example which shows that angle is not important when we are looking at ratios. In this case, the angle is 40. In this case, the angle is 0. But you see the indices are not much different in these cases. So angle dependence, these ratios are not very angle dependent. Now, what are the basic Doppler tracings? Always zoom the area of interest, apply color Doppler, narrow the color box, so you get very good frame rate, adjust the velocity scale depending on which vessel you are looking at, and adjust gate to cover vessel. Usually 1 millimeter or 2 millimeter gate is sufficient, but for smaller vessels like ductus venosus, your gate should be very, very small, 0.5 to 0.7. Then adjust filter, it should be a low filter. High filter is required when in your cardiac settings. And angle close to 0 when we are looking at fetal MCA, because angle of 10 degree corresponds to 2% error in velocity. Angle of 20 degree corresponds with 6% error in velocity. And for ratios, we are not very much bothered about angles. Now, what is your target? What are we looking at? Some are placental tests, some are fetal tests. Umbilical and uterine artery Doppler, these are placental tests. They reflect fetoplacental and uteroplacental resistance. While fetal MCA and ductus venosus, these are fetal tests. They indicate response to adversity. So what do these vessels represent? Uterine artery tells about your trophoblastic invasion. Umbilical artery tells about your placental venous obstruction. MCA tells about brain sparing. Aortic ischemas give information about redistribution of the cardiac output, and ductus venosus is indicator of myocardial function. It is a direct indicator of load of the fetal heart. From here, we get all percentage. There are various ways. Many softwares, reporting softwares have inbuilt mechanism of putting percentage. You just put the values and gestation rate, it will give automatic personalized. Or this online www.varsino.com. This is the free website which can be used for a number of things. www.pediatrics.com is another website which can be used freely in these cases if you don't have reporting software for that. Now coming to uterine artery, it is the branch of anterior division of uterine iliac artery. It enters the myometrium at the junction of uterine corpus and cervix. So why to look at in first trimester for screening of preeclampsia, in second and third trimester for assessment of fetal growth restriction. Remember that once the umbilical artery becomes abnormal, the value of uterine artery is lost in terms of fetal growth restriction. And we start to look at it 11 weeks onwards. So from 11 weeks onwards, each and every patient should have uterine artery Doppler in his reports. So how to look at it? You can have transabdominal method or transvaginal method. Usually we go for transabdominal method unless you are already looking the things transvaginally. So in transabdominal method, in first trimester, you have to look at the sagittal section of uterus, cervical canal or internal os is identified here. After magnification, put in color, tilt the probe to right side, you will get right uterine artery. Tilt the probe to left side, you will get left uterine artery. While in second and third trimester, you have to look for the uterine artery in between the anterior superior iliac spine and pubic symphysis. Midway between that, you identify the uterine artery crossing the iliac arteries. Here pulse wave Doppler is used. Sample volume is placed 1 centimeter downstream the crossover point here, just above this. Sample gate is 2 mm usually, depending on the caliber of the uterine artery. Angle of insinuation should be less than 30 degrees, though it is not important, but for a good waveforms, you go close to 0. Important thing here is PSV should be more than 60 centimeters per second when you are looking at uterine artery. If the PSV is less than 60 centimeters per second, it is not uterine artery, you are looking at arcuate artery. This is very, very important message. And when 3 consecutive waveforms are obtained, PI is measured and mean of right and left is taken. In non-pregnant state, there is high resistive flow with low diastolic flow, and there is early diastolic notch. Now, few words about notching. This diastolic notch was very, very famous in previously. Every talk, everything was discussed, everything was based on notch. But nowadays, this notch has lost its importance. We don't give importance to this notch. We are discussing in terms of only pulsatility index. Now, trimester-wise, as shown here, as the gestation advances, the impedance goes on decreasing, resistance goes on decreasing, and diastolic flow goes on increasing. So the PI values are again coming low. Now, these are the cutoffs given depending on the trimester, the first trimester, second trimester, third trimester. But instead of using cutoffs, always use the language of percentiles. Uterine artery is falling on such and such percentile for this gestational age. This is the best language to use instead of using cutoffs. And abnormality is when the uterine artery PI is more than 95th centile, it is called as abnormal, and it suggests fetoplacental insufficiency in later gestation and as an important cause of fetal growth restriction. And all of us use low-dose aspirin from first trimester for prevention of preeclampsia. This is very, very important use of this. This is a very nice article, how to record uterine artery Doppler in first trimester, who are interested in looking into it in very deep. Now coming to umbilical artery Doppler. It arises from internal iliac arteries from the fetus, carries deoxygenated fetal blood to placenta, and oxygenated blood returns from the placenta by way of umbilical vein. When do we look? After 24 weeks. And if you suspect twin-twin transfusion syndrome in monochromatic twins, you can see 2 umbilical artery at any stage of gestation. Why? It reflects fetoplacental resistance. We look at it when there is risk of fetal growth restriction or poor perinatal outcome, and it is a very important tool in staging of twin-twin transfusion syndrome. How to look at it? We have to sample free floating loop in singletons. If we take at the level of insertion of a placental site insertion, you get low PI values. If you take the site of umbilical cord insertion at the fetal abdomen, you get high values, high PI values. So best way is free floating loop. In multiple pregnancy, you can use this thing at the level of umbilicus to identify the fetuses. Importantly, fetus should be at rest and not breathing. Angle of insinuation is not crucial. And when there is 2 vessel cords, single umbilical artery, the caliber is large, dynamics is different, so you have to report cautiously. Diastolic blood flow cannot be detected in first 10 weeks. It is detected after 15 weeks of gestation. Now, what is normal flow? Trimester wise, as the gestation advances, the resistance and impedance goes on decreasing, and diastolic flow goes on increasing, and PI value is falling. So there are nomograms available on net. This is very nice article. Again, this is www.barcelona.com to get all the values. Always use percentile instead of cutoffs. Normal is umbilical artery PI falling on less than 95th centile. Now, what is abnormal? High uterine artery, high umbilical artery PI falling more than 95th centile. When it has got high pulsatility index, it indicates that 30% of villi are damaged. When there is absent end diastolic flow, the more than 50% villi are damaged. When there is reversal of end diastolic flow, as shown here, the 70% of villi are damaged. It is very, very severe degree of placental insufficiency. So this is normal flow. This is absent end diastolic flow. You can see here no diastolic flow here as compared to normal diastolic flow. And in third case, you get reverse end diastolic flow. The flows are going below this line. Again, another important thing, look at the trend. See, in this case, the umbilical artery PI is below 95th centile. You can see it normal, but when you are seeing at 2 occasions, it is rising trend. So these fetus should be examined very stringently. The follow-up should be done very frequent follow-up. Now, here are some tips. If PI is abnormal, measure both umbilical arteries and use more normal values. Sample approximately made umbilical cord, that means free floating cord. Perform Doppler at the start of scan, and if abnormal, repeat at the scan, end of scan. See, umbilical artery readings, they are sometimes very, very erratic. You get abnormal values many times. So you have to repeat the values because there are so many twists and turns in umbilical cord. So you may get abnormal values because in a normal AGA fetus, low risk fetus, there is no reason to get abnormal umbilical artery. So you have to report and examine wisely. Fetal breathing and maternal breathing. These two important things, they should be taken care of when you get abnormal values. Coming to middle cerebral artery, we are looking at middle cerebral artery because it is seen to see fetal growth restriction. It is very, very important thing, MCA Doppler to measure PI and CP ratio. And another thing, it is important non-invasive assessment of fetal anemia by measuring fetal peak systolic velocity. What happens in hypoxia? Because of fetal hypoxia, the carotid receptors, chemoreceptors are activated, and they provide more blood to vital organs like adrenals, fetal heart, and fetal brain. And because of that, you get brain sparing effect. More blood flow is flown to fetal brain, and for that reason, the MCI-PI drops. While in anemia, because of fetal hemolysis, there is anemia and drop in SCT. Flow velocity is increased. There is high flow velocity which causes MCA-PSV to rise. So how to get the MCA Doppler? You have to get axial section of brain, go to base of skull, magnify it, put in color, you get this beautiful circle of Willis, and put the cursor, get just at the origin of MCA as shown here, and you get this beautiful graph, beautiful lining. Again, important, maternal breathing and fetal breathing should be taken care of. Many times you may ask the patient, you have to ask the patient to hold the breath for better visualization. Normal, these are the normal values in first trimester and second and third trimester. So normally MCA, middle cerebral artery, have high resistance flows as opposed to uterine and umbilical artery. Here is different. Here you have got high resistance flow. Normal PI should be above 5th centile. Now, MCA Doppler abnormal, increased diastolic flow indicates brain sparing fetal outpatient. It is a part of fetal outpatient to hypoxia. Abnormality is when the PI is less than 5th centile. So there are pitfalls for MCA Doppler. You may get reversal of diastolic flow in fetal MCA, maybe because of compression, excessive compression of probe. Maybe hiccups. Hiccups actually a good sign. It tells you that the sympathetic parasympathetic activity of central nervous system of baby is working. It is good. The baby is not hypoxic. Impending fetal death and various cardiac anomalies. Now, cerebral placental cerebral placental ratio needs mention here. It is a ratio of MCA-PI to umbilical artery PI. Normally, what happens at any gestational age, MCA-PI is more than umbilical artery PI. But what happens in hypoxia, umbilical artery PI is high. It goes up and MCA-PI goes down. So CSP, CPR goes down. Almost it may go less than 1. It is measured again in centiles. It has got greater sensitivity than assessing MCA umbilical Doppler in isolation. Less than 5th centile is abnormal. Low or abnormal CP ratio is associated with adverse perinatal outcome. In many cases, reverse can be used. That is umbilicocerebral pressure can be used. But important message here, CPR can be abnormal even when individual PI in MCA and umbilical artery are within normal limits. Umbilical artery may be below 95th centile, but on higher side. MCA may be above 5th centile. It may be on 7th or 8th centile. But finally, you may get abnormal CPR ratio, and that is worrisome. Again, another important message here. CPR is a surveillance tool. It is not a trigger for delivery in late gestation, in late FGR. In late FGR, trigger for delivery is abnormal CTG. This is very, very important message. Now, next is ductus venosus Doppler. It is a small trumpet-shaped connection between umbilical vein and IVC. It carries oxygenated blood returning from the placenta directly into right atrium. So when and why we should look at between 11 to 13 weeks, 6 days. It is a screening tool for aneuploidy, and it is seen in many cardiac defects. In second and third trimester, there are 4 important reasons. Number 1, for monitoring of fetal growth restriction. It is a very, very important tool for the trigger of abnormal ductus venosus is a good trigger for delivery in early onset fetal growth restriction. Then assessment of cardiac function and strain. Number 3, assessing treatment response in supraventricular tachycardias. And number 4, it is used staging in twin transfusion syndrome. Severe degrees are depicted by this abnormal ductus venosus. Ductus venosus valuation is cornerstone for assessing when to deliver in early onset fetal growth restriction. This is very, very important and basic. In early onset FGR, the trigger for delivery is abnormal ductus venosus till 30 weeks. And beyond 30 weeks, you look at abnormal umbilical artery. And in late FGR, CP ratio is not trigger. The trigger for delivery in late FGR is abnormal CTG. Now, how to look at it? Fetus should not be moving air. We in quiescent state. Right ventral mid visual is taken, magnify, put in color. You look at umbilical vein, IVC, and look at the aliasing at the level of ductus venosus. Here, sample gate is very, very small because this is very small 0.2 millimeter diameter vessel. So sample gate is small. Angle of insolation, again, close to 0, less than 30. Low frequency filter is required here because the vessel is very, very small. And high sweep speed should be there. High sweep speed means the number of flows here should be only 4 to 6, not more than that, so that you can study very nicely and neatly. In second trimester, you can use oblique transverse plane of abdomen to catch this ductus venosus. It is at the far end of continuation of umbilical vein. It is in line of umbilical vein. You can detect it by aliasing. Now, normal, it is triphasic wave. You get 3 forms: S wave, D wave, and A wave. S wave is ventriculosystole, D wave is ventriculodiastole, and A wave denotes atrial contraction. And there is always forward flow during atrial contraction. This is very important and normal thing. Now, what is abnormality? There are 3 abnormalities. Number 1, high resistance in ductus venosus. That is high PI in ductus venosus. PI falling more than 95th centile. Absent A wave as shown here, and reverse A wave as shown in this image. So all these abnormalities tells about low or high sufficiency of acidosis in FGR fetuses, and it is the trigger for delivery in early onset fetal growth restriction. These are another pathological conditions that produce abnormal ductus venosus waveforms arranged by their cardiovascular etiology. These are usually not associated with fetal growth restriction. This is another list. Now, last one is aortic stenosis. This is a controversial thing. Many of us don't use aortic stenosis in our routine practice. Aortic stenosis is the area between left subclavian artery and ductus arteriosus. This area is aortic stenosis. So what happens normally? The highly oxygenated blood from left ventricle comes down to descending aorta and supplies head neck vessels, supplies to brain, and that comes down. And mixed oxygenated blood, which is less oxygenated than left ventricle, it comes from right ventricle, pulmonary artery, ductus arteriosus, and it may go up or it may go down depending on the resistance. If the resistance in placenta is less, in most of the cases, in AGA cases, in low risk cases, there is forward direction. That means the blood go through this direction. But when the resistance in MC is less, as in late FGR fetuses, because of brain sparing effect, there is backward direction. That means the blood flows back to this direction. That means the brain is getting less oxygenated blood as compared to normal fetus. Compare this, and that this is the cause of poor neurological outcome in these babies. So it is ideally done between 30 to 34 weeks. Normally, aortic stenosis always reveal forward flow during diastole, and reversal of flow in aortic stenosis precedes ductus venosus abnormality by 1 week. So this is the normal flow, upward stroke of left ventricle, sharp dip of right ventricle. You may get small early systolic reversal like this by right ventricle, and this is the normal flow. This is the abnormal. You get the reverse flow in this direction. But aortic isthmus require many studies, many more studies to get incorporated in your routine practice. Routinely, most of fetal medicine specialists, most of imaging specialists, most of radiologists do not use aortic isthmus waveform. Those who are more interested in aortic isthmus can go through these articles. These are very, very nice articles. Very detailed is given in this. Now, pitfall in this, the net reversal is seen only after severe umbilical artery abnormality and becomes abnormal before ductus venosus. That means you are looking at very late stages, and it is highly specific but not sensitive. Again, more studies are required. So to conclude, color Doppler is now integral component of almost every obstetric ultrasound. You should know basics of obstetric Doppler, how to look at the vessel, how to put the sample, what should be the velocities. Not only you should know the technical aspects, but also interpretation of is very, very important. Because if you got once abnormal value, don't jump on any conclusion, because you have to repeat the studies for after half hour, after 24 hours also for a final result. And most important message here, abnormal Doppler is not equal to cesarean section. For FGR, you have to go by Barsinger protocol. Cesarean section is reserved only for stage 2, 3, and 4. Stage 1, when there is umbilical flow, diastolic flow is there in umbilical arteries, you can give trial of labor. Thank you for your attention, and sincere appeal to support and vote me for my candidature. I am contesting for Genetic and Fetal Medicine Committee. Thank you.
Chairpersons and experts, please give your views.
So, Jyoti Madam, Jyoti Chavan Madam.
Yes, it was an excellent presentation. We got to know so many technical points out here, and the aortic isthmus issue was very beautifully explained. I think there is more scope of studies there, and I think he's been very articulate in his presentation as to when we should intervene and when we should not intervene. Doppler is not an indication for cesarean. That is the take-home message that I take. I think it was very beautifully presented. And
Ponnuswamy Madam.
Excellent presentation, Dr. Sujit. Yes, it was a mesmerizing talk, and it cleared many of our. Yes, somebody. Okay, and I take this opportunity to thank our conveners, Dr. Umayal, Dr. Vijaya, Dr. Radha Lakshmi, and one more Shweta. Yes, because to give me the opportunity to share the platform with all stalwarts, and it's really an interactive session, very well appreciated, and need for all obstetricians. And thank you. Thank you. And I want to inform you that I am contesting for the post of ICOG Governing Council member. So I need all your support, and you tell all your friends.
Definitely, madam.
Yeah, you already told me.
Best wishes, madam.
Best wishes, ma'am.
Thank you.
Best wishes, madam.
Thank you. Yeah.
And Uma Devi.
Best
Uma
wishes.
Devi. Uma Devi, are you there? Uma Devi.
Yes, yes, ma'am.
Yeah. Please.
Good evening, ma'am.
So Uma Devi is the dynamic secretary of Tirupati.
Good evening, ma'am. Good evening, Radha Lakshmi, ma'am. Good evening, all the dignitaries, ma'am. Actually, this was an excellent presentation, but one doubt, ma'am.
Yes, ask
how
Sujit.
frequently? Can I ask, sir, ma'am?
Yeah,
sure.
Yes, he's there.
Sir, what is the percentage of you people doing Doppler scans, sir? Do you suggest Doppler scan for every patient, even though if the patient is not very sick?
Every growth scan should be a Doppler scan. There should not be a growth scan without Doppler. Every growth scan should be along with Doppler scan, especially after 30-32 weeks. Because the most important thing is late FGR, because you know the sudden IUDs which we have seen in previous days. Nowadays we have we're looking at the position that they are because of late FGR, because a normal AGA fetus at 32 weeks can land up in late FGR at 36 weeks. So FGR, the color Doppler study at 35, 36 weeks can only diagnose late FGR. There is no other way.
Okay. Okay.
So growth scan at 30, 32 weeks, okay, we can have a Doppler. But 35, 36 weeks growth scan with Doppler is the most important thing to diagnose late FGR cases and to avoid all these late
complications like that.
Yeah.
Okay. Okay, sir. Basics of lung.
Everything.
Yeah, ma'am. Please, ma'am.
So when everything appears normal and all the parameters appear normal, still we need to do color Doppler 35, 36.
Yeah, there are two schools of thought actually. You have to whether you should do Doppler in all patients or whether you should do Doppler in only patients of fetal growth restriction. But most of the clinicians look at the Doppler in each and every patient after 30, 32 weeks.
Sir, I have a suggestion to make. I think the high-risk pregnancies, especially those having diabetes or previous bad OH, they should be considered for this Doppler study, especially after, say, 32 weeks.
Yeah,
That's
it's
my
good suggestion, ma'am. It's good suggestion, but with practice, it doesn't take more than 2 or 3 minutes to look at all these vessels. With practice,
But we
it is
need experts like you also.
Oh, everyone has to become expert. Everyone is using sonography machine in his clinic. You are looking at follicular study in early pregnancy. Just put one step higher. You look at Doppler. It is almost all patients going for growth scan at your center. Just spend 5 more minutes and look all these vessels. It is very, very easy and easy to interpret after a few cases.
Sir, my doubt is if the baby report is coming as 50th centile, okay, you do a scan at the 22 weeks or late 30 weeks. The centile comes as 50th centile. Still, you insist on Doppler, sir, or if it is okay, the growth
No,
is okay.
the estimated fetal weight between 50th centile to 90th centile is the safest zone for baby.
Something above 50, yes, sir.
Yeah. If the estimated fetal weight below 10 centile is again FGR and SGA. These are high risk cases. But the zone between estimated fetal weight 10 centile to 50th centile, this is the zone where we get.
Actually, I usually go with the centile, sir. If it is less than 50, I will do Doppler study, sir. That is how I do in my practice.
It is a zone where we get late FGR cases. If even if the estimated fetal weight is less than 10 centile, more than 10 centile, but less than 50th centile, this is the high risk area for late FGR cases.
Thank you, sir. Thank you, sir.
Sridevi.
Yes, ma'am. Good evening, ma'am.
Yeah. You were.
Sir, sir has excellently presented the topic, ma'am. I have one doubt, ma'am.
Ask sir.
Sir, if it is a twin gestation, sir, one twin has become IUD, then how to follow that second twin with Doppler, sir?
No, it depends on whether the twin is diamorphic, diachronic, or monochronic twin.
Okay, sir.
If it is DADC diachronic twin, we forget. It is altogether different pregnancy. We don't pay much attention to that. But if it is monochronic pregnancy, then the problems are there. And then again, it depends on gestational age, because the death of one baby causes severe hypotension in that baby, and all the blood from normal baby is going to that diseased baby. So neurological problems are seen in that normal baby. So we have to look at Doppler of all this study is essential in those cases.
Nice presentation, sir. All the very best, sir.
Thank you.
Rekha Rajesh.
Sir, it was a wonderful presentation. And I think today Doppler is there to stay. And like sir said, we all do 32 weeks Doppler. Growth in Doppler is actually done in my practice. I find it very useful. And we can pick up these late FGRs, and then decision making is easier. And then planning the outcome of the pregnancy, counseling, everything. Doppler is a very big, it plays a very big role. And I think, sir, you presented very, very well. And thank you very much. And wishing all the contestants all the very best. Thank you.
Thank you, dear. Thank you, dear.
And I thank Jyoti Chavan, madam, Punnaswamy, madam, Rekha Rajesh, Uma Devi, and Shri Devi. And I request all of you to support Sujit, myself, Umayul, Vijaya, and Shweta in coming elections.
Thank you.
Chandra Panaswamy madam is contesting for ICOG chairperson. ICOG member.
Yes.
Governing
In
council
the
member.
month of September.
Council ICOG.
And
Sure,
Rekha,
ma'am. Our best wishes.
And I request you to come to our society in near future for that ISAR conference. Okay.
Right.
Thank you all. Umay, can I request now Vijaya and Shweta call to take over the second session?
Yeah.
Thank you, madam.
Hello.
Yeah,
Yes.
Vijaya.
Yeah, good evening, everyone. And after the wonderful session on Doppler in obstetrics, which is the bread and butter of obstetrics, I should say, without scan, there is no pregnancy growth or whatever may be. And now we are going to the second session, very, very interesting session, obstetric hysterectomy. The technique and the indications and everything differs. And I have a pleasure in inviting Dr. J.M. Kannan, ma'am. Can I have the CV?
No. First introduce the experts.
Who's that Raki, ma'am?
Raki.
Yeah. Yeah. Can you please put the slide of Raki? Yeah. Raki, ma'am is Chief Fertility Specialist and Gynec Laparoscopic Surgeon in Sai Test Tube Baby and Laparoscopic Center, Jabalpur, Madhya Pradesh. And she is a life member of IAGE, IMS and AMS. And she's the president of Jabalpur Obstetric Gynec Society 25-26. Got a lot of awards and lot of awareness programs she's conducted. And very happy to have you, Raki, ma'am, today on my webinar.
Next.
Can I have Dr. Gayatri? Yeah, Gayatri is our own TNFOG Society, HOD Department of Rajaji Hospital, Madurai Medical College, and former VP, Madurai Obstetric Gynaecological Society, UG teacher, PG teacher for the past 19 years, and UG PG examiner for the past 12 years. And her field of interest is high-risk obstetrics and endogynecology, and will present a lot of papers and publications. Welcome, Gayatri.
Thank you, madam.
Yeah. And Dr. Padma Shukla. Yeah, she's an associate professor, Reva Obstetric Gynec Society president.
Shweta will introduce.
Okay.
I request Shweta to introduce the chairperson.
Yeah. Sorry, Sweta, please.
Yeah. Shweta?
I welcome Dr. Padma Shukla, madam. She is president of Reva OBGYN Society, and she has number of awards to her credit, like CS Dawn Award. Reva Society is very active society at MP, and in their category, they keep on, getting some award or the other for the society. They have Durusha Award, Mylan Smriti Award, and IFS Sukanya Award, and she has more than 15 publications. She is a medical college teacher. So we are very happy to have you, Padma madam. Are you there, madam? Okay. Padma ma'am, welcome ma'am. Next is Dr. Anju Verma, madam. I am from Gwalior and she's from my hometown. She is consultant at Dr. Verma Hospital and Fertility Center, Gwalior. She is secretary of Gwalior Society, and she is also organizing secretary of MP ISAR Conclave. And the first IVF baby of Gwalior credit goes to her. And she is also FICOG, and she is member of numerous other societies. Welcome, Anju Verma, madam. Are you there, madam?
Yeah.
Yes.
Padma
So
Shukla madam
next-
also joined.
Yes, thank you, Sweta. Thank you.
Welcome, madam. Welcome, madam. Then Purnima Sarvanan, madam. She is president of Erode OBGY Society, and she's a consultant and fertility specialist and member of IMA Women's Pink Health. Are you there, Purnima, madam?
Yeah.
Yes,
Purnima.
yes, ma'am. Yeah.
Welcome, madam. Welcome, madam.
Thank you so much.
Next, we have. Okay, now I request one of the chairpersons to introduce Dr. J.M. Kannan, madam. Dr.
Yes, ma'am.
I know everybody wants to talk about madam. So
No, I want to introduce J.M. Kannan, madam.
but
No,
we will,
I want to introduce.
we have to ask chairpersons, madam, then we will add our points.
Okay.
Yes, any
Chairpersons
chairperson.
only.
Yeah, please.
Chairpersons only.
So I will take this opportunity to introduce Dr. Jam Kannan, ma'am. Ma'am is a well-known personality. She doesn't need any introduction. Ma'am is Vice President Foxseed in 2018, and she is a Managing Director, Garba Center Raksha Ratna. Fertility Center, Chennai and Trichy. And she is a legend of Foxy 2025. Distinguished Service Medal Award she has received in 2018 and first Indian to receive this in RCOG. The madam has got so many awards. She has got President of India Medal for Outstanding Performance in MBBS, winner of 13 medal and prizes in MBBS. Great, ma'am. State first in MBBS and she was first in MBBS and university as well in MD. And Best Paper Award 4 times. Best Book in Medicine Award 2 times from Government of Tamil Nadu. Durusha SN Pandit Award and Foxy Community Work Award she has got. And winner of the Duffer and Countess Merit Scholarship for MD study periods. Best Doctor Award for Tiruchirappalli 1999. Lifetime Achievement Award and from IMA in 2009. Lifetime Achievement Award TNMGR Medical University 2011 and honorary FICOG in 2011. Felicitation of InStar Society India 2017 award and madam has won this
my work in Tamil
award for Tamil in 2018. So welcome, ma'am. Dias is yours, ma'am. You have got so much great list, and I'm sorry to fumble because some of the things I didn't.
That's very nice.
But ma'am, welcome for your talk, and we
Okay.
want to hear you, ma'am.
Yes.
Madam in pink looks so welcoming.
Madam,
suits
you are
so
having so many fans to introduce you, madam.
Thank you, ma. Thank you, ma.
I'm your
That
friend,
really makes me so proud, Today itself, I got 3 lectures to be done. I'm so happy that I'm going to speak on obstetric hysterectomy nationwide with all your people right from Punjab, Jabalpur, down to E Road. I'm very happy to see all of you here. And obstetric hysterectomy is one thing which in a mind, it gives you a dreaded feeling. But however, as we go up, when we place it earlier, you really feel that you are doing the best society service to this humanity. Historically, when we look at it, Kalyankar et al. With Dr. Gauri Gadappa has done an excellent work on this obstetric hysterectomy, and his videos on placenta accreta symptoms are videos on the patients are excellent. In in 1768, animal studies were done, and only in 1869, the first hysterectomy in a patient was done after in delivery. But of course, the patient died. Like our Robert Edward, who had 300 failures before he had the first success. Even his first success aborted at about 22 weeks. And then in 87 years later, it was Eduardo Porro from Milan who did the first successful procedure. And now we are not very bad. 5 per thousand in developed countries, 6 to 10 in developing countries. Obstetric hysterectomy is really a high risk operation, not to be very much unscared of. Because of the anatomic relations disturbance with the adjacent organ, the extreme vascularity, the large size of the uterus, and the pressure on the obstetrician, finish madam, by the anesthetist, and by the staff who are standing there. So much hurrying, busying in the theater, we feel we are very much pressurized. In that pressure itself, we may sometimes injure the bladder or ureter. And especially if you have to previous cesarean, it is really a task. Can I do a subtotal hysterectomy? Why not? Earlier, we were not doing subtotal because of fear of cancer cervix, but now you can do subtotal because we can give the patient HPV vaccine. Of course, surgeon skill is very, very important to do a total hysterectomy. However, even if you are the greatest surgeon, please have another obstetrician or another surgeon with you as much as possible. Placenta accreta is the one which is going up so much, and it is almost contributing to 45 to 50% of the obstetric hysterectomies. Still, uterine atony is 43%. Placenta previa also contributes to another 16%. Uterine rupture still it is about 11% in some of the areas in India. However, it has come down to 1% also. You see, as in USA, the number of obstetric hysterectomies for PAS, placenta accreta syndrome, has come down from 10 to 20 in 2013 to just 2 because of the various lovely procedures which have been nowadays put in cases of accreta placenta cases. The Indian data is on this obstetric hysterectomy is from Maharashtra. PPH is 35%. They also accept rupture uterus 14%. PAS is 50%. There are two things which are very, very important, which are avoidable. Are 1% is broad ligament hematoma, and peer process still contributes to 1 in 100. Right now, in my area, Tiruchirappalli, we have a case of delivery septic encephalopathy. What to talk about it? I have no idea. I really feel sorry for the obstetric scenario, both on the part of the patient as well as on the part of the treating obstetrician. This is a very, very sad affair. Broad ligament hematoma also is totally prevented if only the surgeon, the obstetrician, has taken care to inspect the vagina clearly. Wait for 4 to 5 minutes until you don't see a swelling in the paravaginal tissues. That is why I'm insisting on these two things. Now, we know well rupture uterus and failed atonic PPH with all the sutures is the most important dominant cause for doing an obstetric hysterectomy. And we know well, these are the vessels which have to be taken up. The vessels, even though we say 3 clamps, but note that here you have 3 vessels. And then when you come here, you have 2 vessels. And again 2 vessels. When you come down, you have large number of vessels. And this has to be kept below the uterine artery level very much in order to have a perfect hemorrhage control. We traditionally time tested said about first clamp, second clamp, and third clamp may also have a fourth clamp. Also, please note that is required. In India, in some of the areas like eastern part of the India, still dominates with uterine rupture. 75% want to talk about it. Placenta accreta in those areas are only 5 per 1,000 because they have more cases of vaginal delivery than cesarean section. Deep surgical site infection is also a very, very normal cause for them. The predictors of maternal outcome in a patient whom you have taken to theater after a vaginal delivery, or you are doing a cesarean, you are proceeding with hysterectomy. 2 things you require to know. Is the patient having 90/60 BP? Yes, you can salvage the patient. Is you are having a good blood transfusion facility. If only you have these 2 things, your chances of success above 98% is sure to be taken up. Now, having decided that there is a need for hysterectomy, where is it to be done? Always transfer to a tertiary care center. Call the team and tell them to back it up with a physician, blood transfusion, everything. At the same time, while you're arranging the ambulance, make a local to-do checklist. You take the blood for cross-matching, you put the patients on proper IV fluids, catheterize the bladder, pack the vagina if it is required, but normally I don't prefer a packing of the vagina in cases of atonic BPH because vagina can hold up to 2000 cc's. So packing is not too good, but better to do a uterine packing. Communicate with the referral centers adequately. But what if I don't have, I am in a torrentially raining time, no relatives are by the side of the patient except an old lady mother who has been there, what to do? I have to take up the case. I can't say no to the patient. Explain the circumstances, write the case sheet very clearly with that nurse who can write the details clearly and proceed with the hysterectomy if you are a single doctor with a single anesthetist. What are the things you require for preparation? Good counseling. Then good venous access with 116 and 118 kg when flans. Blood, if you can, you have to arrange, even if it is 30 kilometers away, the blood bank is there. Anesthetist must have an expert anesthetist. I always prefer an anesthetist from Egmore Maternity Hospital, which is the biggest center in Tamil Nadu, dealing with about 20,000 deliveries per annum. These centers, the anesthetists who are there, every day they would have had a case coming to theatre as an emergency, so they know very well about giving anesthesia. Kindly do not accept a laparoscopic anesthetist because he can put the patient head down nicely, or a patient who is used for head and neck because he can tackle with the neurological system. A person who is tuned to obstetric anesthesia and managing the blood dressing is what is required. If you are given epidural or anything, may require general anesthesia also. Airway has to be maintained. Appropriate medical facilities and salvage is also required. Now, regarding the instruments, I went into the theatre with a cesarean. So I always keep 2 bins of cesarean. I rarely have a case of hysterectomy bin. Or I am working in a corporate hospital where in between I went in for an emergency hysterectomy. So they were not able to supply me proper instruments because just now they have finished with the ENT surgery. So the nurse will be looking up and down, side and back, front and back. Please, madam, wait. I'll give you instruments. Please tell her, cajole her to give at least a tray with few forceps and 6 long artery clamps that are more than important. You see what I have put, 6 long artery clamps. By the time the anesthesia is given and that you have opened the abdomen if you are vaginal or if you are doing a cesarean, just with the 6 clamps you can clamp the vessels. Self-retaining retractors, choice of yours. If it is available, you may not be the chooser, you are the beggar at that time. Kindly note, even if you are in a corporate hospital, you are a beggar. If you are in your own private setup also, at the last minute, at dead of the time, the nurse may not be able to accept because you will be firstly saying, give me honey, give me honey, give me valentine. Your words itself will not be full. She may not understand. She may scare at you, look at you, and you may get a little more angry and you get your emotion diluted. So, if you have electronic sealing devices, push it near your table and choice of retractor if you have. If nothing is available, have an opening of the abdomen with 6 long artery clamps alone. The anesthetist, I have already said, has to balance between hypovolemia and hypervolemia and between epidural and jail. He has to walk a thin line. And if he is over perfusing the patient, again, the chances of post-hysterectomy, hypertensive problems, eclampsia will promptly come in. The length of triad of this hypovolemic shock will also be aggravated by 3 more factors in obstetric hysterectomy. The massive transfusion you are giving will be with hypothermic blood, which has been stored. So hypothermia will be a problem. Please be careful. With all the fluid imbalance, metabolic acidosis, and also coagulopathy, which gets worsened by hypocalcemia. So it is not only our surgery which is successful, the vascular system, cardiovascular renal system also has to be successful in these patients. Now the procedure. The first thing is round ligament identified and clamped, then broad ligament opened, bladder dissected off, posterior leaf opened with parallel to the infundibulum pelvic ligament, ovaries are removed, then come down. This is how we have the first clamp which is put there. Then we have, apart from this, we have the radial arteries which are going. If you have not adequately clamped this one, blood can come from this. Even if before you clamp the uterine artery, these areas will be bleeding. So we have to have a very careful clamp with proper opening of the broad ligament. The second step has to be with the uterine artery. Then you go down and do this surgery. I will show you at the end of it until we master. How do you enter the vagina? It has to be not with the dissection over the vagina, because the difference between the cervical edge and the vagina is so difficult, so thin. Not like a gynec patient where we have a thick cervix and a thin vagina. Here we have to palpate posteriorly and feel a little thickening. At that place, push the hand up and give a sharp pin onto the anterior vaginal wall, and then put your Schienese clamp or long artery clamps on the side. There we finish the surgery. The surgical challenges in these cases are identification of the external loss of the cervix is very important. Dilated blood vessels, already patient is in a pool of blood, friable tissues, and your scare of ureter. Always think about, will you be near the ureter? Will I be near the ureter? Is always lurking you. Even if you are near the ureter, once you have clamped and got the patient's bleeding free, then you can look at the ureter on both sides, look for the peristalsis. If the peristalsis is there, you are very sure that you have not touched the ureter. By a rare chance, you have already touched the ureter also. Nothing wrong, because you have saved the patient. Maybe there is morbidity, but there is no mortality. Can I do a subtotal? I have already said no blood transfusion available. You want to be faster. You don't want intra and postoperative complication. Less skill. Even if you are skilled in an area where you don't have facilities, please go ahead with subtotal. Put the patient on anti-cancer vaccine. Now this is a procedure which I would like to show here. Now you see how we have to put the clamp. The first clamp is what we are putting at the cornual end. It can be around 15 to 20, maximum 30 degrees. The clamp has to be from the uterus this way. Then the next clamp which goes there, you see, the clamp cannot be across. It has to be, see how we are putting the clamp, 45 degrees for the uterine artery. If you put this 45 degrees and go towards the uterus, your chances of touching the this ureter is not there. And secondly, put only single clamp. Because if you put more clamps, your chances of catching the ureter are more. Now, you see the cesarean ward. Now you have put this clamp. There is only one more small area which you have to come, and there it goes. Now I'll go to the next one. Peripartum hysterectomy is another thing. There may be even as much as 8.9 has been done. But Indian scenario, we are doing less than 2 per 1,000 cases. But this hysterectomy is not so popular. Very rarely peripartum emergency is done. Now, I have another video in which I am going to show you how we are dealing with the placenta accreta previa. See the upper incision, classical vertical incision. You see the baby with the amniotic sac. Then just nick the sac, take out the amniotic fluid, out comes the uterus. What a lucky procedure, there is no bleeding. Now you have the cord. Don't try to pull the placenta. Suture the cord, clamp the cord, ligate the cord, and proceed with suture of the uterus. You see, the placenta is there in the lower segment. Now you see the suture of the uterus. Aram say you have done the suture of the uterus. Now you proceed with your hysterectomy, by which time your bleeding would have come down. Now, then I show you the third one, where how to individualize the uterine arteries. You see that uterine artery and vein? You see, you have to be very slow, because it's not your hurry which is going to help you. Because by your hurry, you may catch the ureter. See now how it is, right angle forceps is put and the clamp is put. This is how we have to have the ureter, uterine artery and vein and this. Now, in all cesarean sections, we don't dissect the bladder down. So after the uterine artery clamping, you have to dissect the bladder down in all cases, non-placenta accreta symptoms, and push the bladder very nicely, and then take out the uterus. These are the steps which are very, very important for you to do it. And open this posterior very, very clearly and take out. Again, I'm showing the uterine artery, how you have. This is a very, very tricky area where don't be in a rush to take out the uterine artery. Yes, we are going to discharge the patient healthy with her baby. Discharge medications, put her up. Care after discharge from the hospital, one nurse has to keep a follow. Because we are doing 1 in 8 per thousand cesareans, cesarean deliveries. If we have to have one nurse every 4th day, 5th day, call the patient and cajole her. Because her family, first 1 month, they may be happy that she is alive. But after that, the husband starts feeling. She doesn't have uterus, so she is not a woman. I myself have heard a PhD doctor in Perambur, that is Perambalur, that is 40 kilometers from Tiruchirappalli, coming and telling me, Madam, my mother is not a woman. I asked why. She doesn't have uterus. I was surprised that a PhD in biochemistry is saying that she is not a woman, especially after delivery, because she is a young woman. The husband will feel that he is not getting the satisfaction in sexual life, mainly because she doesn't have uterus. But that feeling should be taken out by a proper counseling, and a mental health state requires a very, very prolonged support. It is not only your surgery and taking care of avoiding the maternal mortality, it is also the prolonged morbidity of the mental stages, which is very, very important. That is why in UK, this mental health foundation is taking up a big step, especially with Kat and Charles going on very nicely with that. Thank you very much for your patient hearing. I stop sharing my this thing. Love to hear your comments.
Ma'am, that was really wonderful, and you have shown it a very, very clear way. But I know obstetric hysterectomy, how tough when in emergency, when we are all panicked and we are really thinking of all the audits and maternal mortality meeting at the government setup. Really, it gives us very tremor and trembling. So it looks so easy, and the angle of a clamp for the uterine artery and identification ureter, very, very important tips, madam, you have told, and it is very, very beneficial to viewers. I'm very happy that you have chosen this topic, because that was your choice and you have chosen a very, very wonderful topic, ma'am. Thank you so much, Jay, ma'am. And you are...
I saw all seniors like Radha Lakshmi, Vijaya, Umayal, sitting there, Chandra Pannasamy, all these people I know, Padma Shukla, so many senior people are sitting there. What can I talk? I have to talk something beyond all of you with my experience of what I say. 1970, I started my career. First delivery was on 17/1/1970 with the forceps, promptly cervical tear. I sutured, of course. And 55 years, even 1 month ago, I did a cesarean also. So I'm still into my work of surgery, and I would love to present something with my experience, not with the textbook details. That is why I brought this, how to identify the uterine artery and isolate it. If you isolate it, 100% you are sure that you are not with the ureter. Thank you. I wish all of you who are going for election, wish you a wonderful time after a successful election. I don't say success in your election, wonderful time after a successful election, and bring something creditable to all the obstetricians and gynecologists of our country, 45,000 members, biggest organization in the world of a society. Thank you.
Thank you, madam. Thank you for everything.
Thank you so much, madam.
Wonderful
Very nice
presentation,
lecture, madam.
Thank
you,
you,
ma'am. It was a mesmerizing talk.
Thank you, madam. Very nice lecture. But I think still every gynecologist in practice, in private practice especially, is scared to do obstetric hysterectomy.
Very true.
Madam, I would like to...
Always call somebody by your side. That is why we want to have a disaster management group in every society.
Yes.
So that you give call to 2-3 people. 1 or 2 may be able to come. They be by your side. And after the surgery, when you go out and talk to the relatives who are a big crowd, at least you are not isolated. You have 2-3 people with you. They will be little quiet. Because you spend a sleepless night, your BP goes up and your pulse rate is also varying after an obstetric hysterectomy.
Madam, any opinion regarding internal ligation rather than obstetric hysterectomy?
That's what I said. Placenta accreta spectrum symptoms, they have come out. One thing with internal iliac ligation is when you ligate the internal iliac, anterior branch of the internal iliac and posterior branch is required, especially in cases of placenta accreta, percreta, lower down, because the bladder and vagina are supplied by vessels from the external iliac, which comes through the inferior epigastric artery also. So even if you have done an iliac ligation, the external iliac supplies these peripheral vessels of the bladder and vagina, which sometimes can give to problem. I have faced such a case. That is why in these sort of cases, if you have a facility, you should have the aortic clamp. You put an aortic clamp, you jolly well do a hysterectomy rather than depending on internal iliac. Internal iliac is slowly going out in cases of PAS, lower part of the uterus. Uterine clamp, this aortic clamp is coming up. You put the clamp, you can keep it for about 15 minutes. Take out the clamp. At that time, watch the area. Again, reclamp it. It is very good for you. Just how, as Sujit said, uterine notch is going out of practice. No more talking about uterine notch. Because I do a scan from 1982. I have never looked at the notch because I felt it is naughty. Now, now in 2022, after 40 years, they have felt it is naughty. The same way, the internal iliac ligation, which has been so much talked about, is slowly going away with all the methods which are available for the double vaginal uterine balloon, other things with aortic clamp, which is getting very much popularized. Internal iliac ligation alone, anterior branch alone doesn't help. If you totally die the internal iliac, it becomes a catastrophe after the postoperatively with all the problems of the sigmoid colon. That is why they say aortic clamp is very much required. Obstetric hysterectomy, when it is taken, where do they go for aortic clamp? Unless they are in Kerala where they are tuned to this aortic clamp, or in places where the tertiary centers where they are already used to aortic clamp.
Yes.
I don't know which hospital in these areas are already holding the aortic clamp in their hand. Purnima, you have Erode?
No, ma'am.
Because you
We
are
are
very
not.
near to Kerala. So I thought you will have it.
Madam, Gayatri madam from Madurai is there, madam. She is attached to Madam.
Gayatri, you have a
No,
aortic clamp?
no, madam.
No.
Gayatri,
See?
madam.
All got that suction cannula. For
All
the
of us have a medical suction cannulas because Tamil Nadu government itself has purchased 700 suction cannulas. They have supplied to all the even the smallest hospital doing cesarean section. They were given even to primary health centers having more than 15 deliveries in Tamil Nadu. Panikas cannula, all these things are available. The uterine clamp is only in place. The aortic clamp is only in places where they are getting tuned to paining program.
Madam, my question is,
I am in a
in our area, there is a radiologist. He wanted to do uterine artery embolization before going for PAS surgery.
Yes, perfect. If you are, that is what I showed you, no? When you have made an antepartum diagnosis of PAS of lower segment, you can definitely take the patient to the theater, do uterine embolization, and then proceed with cesarean. Those are all procedures which has been described in PAS. That is why in PAS, 20 per 1,000 hysterectomy has come down to 2 per 1,000. With all these accessible procedures of conserving the uterus has come out very nicely. Even in Trichy, government hospital, the radiology department is supporting with embolization.
And what about that partial resection? Some PPH specialist telling about PAS in PAS cases, madam?
It's a big subject. What they do is you just take out the baby.
Yes.
You don't remove the placenta. What you do is, over the area where the placenta is there, you put small worm sutures on the surface. Okay. So those worm sutures will compress the blood vessels over the maternal surface of the placenta. Once the maternal surface of the placenta is compressed nicely, then you put your dissector in between the uterus and placenta. Remove as much as possible. Still, there will be a small area about 2 inches by 1 inches, which you can cut down and suture the uterus. That is what is being also now talked about. Upper segment, that is not a problem. Your worm sutures will definitely take it up nicely. And once you put the worm sutures over the in the uterus with the placenta under surface, the uterus gets compressed. Automatically, the placenta will be forced to get removed as you put your hand or you put your dissector in between.
Madam, 1 Vicryl is what you put, madam? 1 Vicryl?
1 Vicryl, yes. Vicryl.
I want the experts to share their opinion.
I always use in all these cases of hysterectomy only silk. All silk, which is sterilized silk packs are now available. Silk gives you a better tight feeling with this thing than with even Vicryl. Vicryl, you will have to put 3-4 knots. But with silk, I can just be confident with the 3.
Madam, what is your opinion regarding uterine artery ligation with Vicryl bar catgut? Which you prefer?
Vicryl is preferred because this in the long time, even if there is a small sepsis part, 1 in 1,000 part, Vicryl will keep it up very nicely. Whereas catgut will get within 14 days, it starts reacting. That itself has promote problem. So I always prefer Vicryl. After 2000, I started using Vicryl. Before 2000, rather, we were all using only catgut. 1 catgut, 2 catgut. 2 catgut for cesarean closure. For all these uterine arteries and other things, we were using the Mayo needle. Now I don't know whether anybody has got Mayo needle. I still have 4 Mayo needles with me for vaginal hysterectomy. Vaginal hysterectomy. Because I am a student of Madurai, Gayatri. I have been trained by Bhaskar Rao and Professor Logambal. Okay, one big obstetrician at Madurai, Dr. Govindamal. We did a vaginal hysterectomy outside. We promptly opened the bladder also. And I was sitting with her for 3 days for proper bladder drainage. So I have been well trained by Lohamba for this vaginal hysterectomy with Mayo needle.
Ma'am, with your permission, can I ask the expert to say a few words?
Expert.
Yes,
Gayatri ma'am.
Happy Bajbai and then Gayatri.
Good evening, everyone. Very nice lecture, Jam madam. Madam, I would like to ask one question. In past syndrome, if you think we have to go for obstetric hysterectomy, which abdominal incision you prefer, madam?
I prefer vertical incision on the abdominal wall.
Okay, ma'am.
Right below the epigastrium, just above the umbilicus. Don't have mercy on the patient. Put it 1 inch above the umbilicus, go down. You need not go down because bladder area will be there with the placenta or anything. Right? Because you are doing a classical opening, there is no need for you to go up to 3 centimeters above the pubic symphysis. But be around umbilicus very clearly.
Thank you, madam.
Thank you.
Dr. Gayatri?
Gayatri, madam.
That was a beautiful lecture, madam, and wonderful videos. And because of the increasing incidence of cesarean section, we have a lot of PAS coming up. And we go for 1 or 2 hysterectomy monthly because of that PAS increasing incidence. Madam, what are the steps to prevent bladder injury in this case, madam?
If
Any
you want
specific?
to have a PAS obstetric hysterectomy, you should keep a urologist, surgeon with you, and you should also have a vascular surgeon. Gadapa has given a beautiful video. I put in a Kalyankar Gadapa, GADAPPA. Gadapa from Maharashtra has put an excellent video from, I think, Aurangabad or somewhere.
Yeah,
And
he's from my place.
yes,
Yeah, he is from my place.
yeah, beautiful video in which he has done an elective hysterectomy, and he has taken a video, vascular surgeon, urologist, obstetrician, and one more obstetrician. Two obstetrician, one urologist, and vascular surgeon. Anesthetist team, 2 people. Always keep massive transfusion protocol, MTP ready. 666 has to be kept ready. And open the abdomen and the midline or paraumbilical, make it in the middle of the abdomen. Once, then go, see the fundus of the uterus and deliver the baby. After you deliver the baby, wait for another five minutes until the uterus contracts nicely and closes on over the placenta. Usually, if it is a placenta previa accreta, we all think there is bladder involvement. Bladder is never invaded by the placental tissue because the uterus and bladder is separated by a peritoneal lining. There is Ratnasri gives it very clearly, and he is a big surgeon from Ceylon who demonstrates the presence of peritoneum in between the uterus and cervix and bladder. The vessels which are sprouting on the bladder are from the external iliac inferior epigastric artery bladder. So you will be able to see a nice peritoneal covering over the placenta if only you wait and not touch the lower segment. Once you see that the bladder is already always on a drainage, the urologist will be able to support you with dissection of the bladder away from the uterus. Regarding the vascularity on the side, even if there is big vessels from the inferior epigastric artery, the problem with these vessels is they don't have a good musculature. They are all only vessels with endothelium and a peritoneal covering. There is no musculature. They cannot contract. So the vascular surgeon will be able to support you dealing with the collateral circulation from the inferior epigastric artery. That is why a vascular surgeon is very important. In case you still have a big bleeding, probably you may require, if you don't have an aortic clamp, you may require internal iliac holding, which vascular surgeon can help you coming down 4 centimeters down, all these classic principles being followed. He can give you a nice anterior branch ligation. That is, all these things are very, very important for you to do, and in which case you will have 99% good recovery, just 1% morbidity, taking the patient 7 days to go home. Normally, we may send on the 3rd day after a cesarean. It may take only another 4 days. Your morbidity will be very much less. In case you still require, request the urologist to do a cystoscopy and find out the interior side of the bladder, cystic areas.
Can I ask Anju ma'am to add on? Anju?
Yes. Anju Verma, madam.
I think this is a very excellent lecture. Basically, I am not doing very much this obstetric works, but I think this is very important thing every gynecologist should learn obstetric hysterectomy, because anytime we can face this type of situation in our obstetric practice. And very nice lecture, madam. Very nice video, and very nice inputs you have given to all of us. Thank you. Thank you very much.
Thank you, Anju. Thank you, Anju.
Padma Shukla ma'am?
Padma Shukla, madam.
Are you
Yes,
there,
ma'am.
Padma? Yeah, please.
Ma'am, you have explained everything very beautifully. And as you said, that the preparation is very important. Once you know that this case is going to happen, then definitely the teamwork is very important. Anesthetist Yes, anesthetist who is trained in obstetric anesthesia is really very important, as well as planning, as you have shown beautifully, that the planning of the case is also very important. That once you plan, and every team member should know their role as well when we are treating with the obstetric emergency. And as I have seen that everybody is very interested for the pass. Ma'am, placenta accreta system, you have, although you have explained obstetric hysterectomy very beautifully, ma'am, and videos were very good. And I want to just give my inputs that in cases of past, we have to go for total hysterectomy. And ma'am, one thing I want to tell you that I have innovated one suture through which I am not doing any obstetric hysterectomy in cases of past, even in grade 3 invasion. I am doing all the conservative surgery. I have presented in Dehradun and as well as in Jaipur right now, West Zone conference.
Can you explain it, madam? How will you do?
Ma'am, it's very simple suture basically. That you have to take from anterior to posterior from the myometrium, and then again you have to come from posterior to anterior. But and you have to ligate the suture. That is vicryl only. And what I do, first I ligate the ascending and descending uterine artery. After delivery of the baby, I don't touch the placenta, and just I hold all the ends of the uterine ends. I don't close the uterine rent. And first, I will dissect the bladder if it is adherent. And I used to ligate both the ascending and descending uterine artery. Then what I do, I see the extent of the placenta, and below the incision where the placenta is, I used to tie 2-3 this suture, that is from anterior to posterior, and again you have to come once the bite should be taken from 1 centimeter medial to the lateral uterine wall border, and you have to take from anterior to posterior, then again come posterior to anterior and just tie it. And even I remove the placenta as well after tying this suture, 2 or 3 suture, whatever is required in that case. And then I remove the placenta. So what happens once I remove the placenta, the knot will, the suture will become loose. Then again I used to cut the placenta, this suture, and I hold both the end by the artery, and again I ligate.
Okay.
So the ligation is that much that the uterus should be pink and the bleeding should stop.
Please share the video, ma'am, if you have in this group later.
Yeah.
Sure, ma'am. I will share the
Please
video.
share the group.
And recently I have done, and I have put 7 stitches in that patient. And it was grade 3 invasion, previous 2 section. And the uterus was saved, and patient and baby both were saved.
Thank you. Thank you so much.
So I think in this case, we don't need even, as madam said, we don't require the hysterectomy. And as madam said that internal iliac artery ligation is not required. Actually, it is not effective in that way. So I think it is not needed when you will use my suture.
Okay.
So I have given this name of P suture basically.
Wow.
P placenta, P for Padma. That's what.
Oh, nice.
Nice.
Yeah, please post your video, madam.
Please share in the
Ma'am,
group.
I will share the
Very
videos.
interesting. Can I ask Purnima Saravanan just to say a few? Purnima?
Yes, ma'am. It really gives me an immense pleasure in sharing the forum with Dr. Jayan Kannamam, when a legend and a master in this field talks about a topic, even a deadliest situation where an obstetrician's nightmare, what we face, a maternal mortality, even the deadliest situation can be dealt in a very confident way. Thank you so much, madam. You have given all your expertise in these videos, and also even from selecting an anesthetist and setting up an instrument tray. So we all have to learn all these things from you, ma'am. Thank you, ma'am.
Thank you. Thank you.
Madam, there is one question in the chat box, madam. In the case of PAS, when we should plan uterine artery embolization?
So
If
it
you
is
are already diagnosed a case of PAS, you are not
pre-operative.
going to wait for the patient to go for onset of labor, number one. Number two, you will do a scheduled delivery. Number three, you will always plan it by the end of 36 weeks to avoid prematurity. By 37th week, when you plan, either you can do an embolization or directly proceed with surgery.
So depending upon the case, whether we have to decide whether she wants.
If there is no comorbidity, like diabetes, hypertension, all those things, 36 week end, 37 weeks. If the patient is due on 21st of July, I will deliver the patient by 1st July or 2nd July. Plan it by 20th of June, right now what we are in. Arrange for all the blood, inform everybody, keep things, ask the anesthetist not to have the next case back to back, waiting for him. Give him sufficient support and make everything ready. We should have even this thing, 37 degrees incubator inside the theater to warm up the blood.
Ma'am, we have done a case, shifted the patient to Omandurar, where the interventional radiologist facilities were available. Then he has put in the catheter, then we did section, then he embolized it. Like that.
Yes, yes. We can also do. He should keep himself catheter ready in the uterine artery. Then as you deliver the baby, he will shoot the bullets. That also is possible. That is all depending on the cooperation which you get from the radiologist.
Facilities available.
He is willing to wait until you deliver and shoot the bullets, embolus, that is fine. If he is not willing, you can't help. You will have to ask him to do, and then you have to do the cesarean section.
So
Never have an anesthetist who is leaving as you start the skin closure. That is very, very important in these cases. That is why I always say give double the amount to the anesthetist, because even if you don't get money, it is your name that saves you. This patient will bring another 15 to 20 patients. From them you get your.
True.
Dr. Purnima.
Madam, have you seen any fistula following hysterectomy in your practice? Because I had one vaginal fistula following.
So far, sir, God willing, I have not had either an ureteric fistula or vaginal BVF after my hysterectomy in these cases, very clearly. But of course, in my Madurai Medical College, at that time when I was doing my PG, there used to be 10 to 12 BVF patients in the hospital. They all used to be the paramedical staff supporting us, and we have been well trained in fistulas. I have assisted fistulas, but luckily I did not have. Even I have done a lot of Verdines, I never had a fistula.
Yeah. Okay. We had one case of vaginal fistula following obstetric hysterectomy, which was done.
All right. Maybe patient would have been in a
patient
prolonged.
was happy because she survived.
Yeah, that's what I say. Even if there is an injury on the bladder, don't worry. You can suture it, but you have saved the life.
Time to close down the session.
Nice presentation, madam.
Thank you.
Chandra
Thank you.
here.
All the best for
Madam,
you.
I request you, Jaya madam, I request you to please share video where you have used aortic lamp.
Yes, I will share. I will send you.
And
Thank you,
Padma
thank you,
Shukla
sir.
madam also.
Yeah, I will send. I'll send to Vijaya or Umayal.
Yes, madam.
Or Raki has to send you this thing. Email ID.
Right.
I'll send you that. Okay.
Thank you so much.
Yes.
Padma Shukla
It's
madam.
very useful. IIT class.
Madam. Yes, sure, ma'am.
Thank you,
I'll
madam.
share the video.
Thank you.
No, we take this opportunity to again request all the secretaries and presidents of all the societies. Please vote for all four of us.
And Sujit also five us.
Totally 5 people are here.
4 women and 1 man. 5
5 for chairperson, 1 for ICUG.
Yeah.
Yes,
madam.
All the best to all the contestants. All the best, and we are going to support you all.
Thank you so much.
Thank you.
Thank you,
And all the
ma'am.
best.
Thank you,
All
Jaya
the best.
ma'am.
We are
Thank
going
you
to
for
support.
joining.
Thank you.
Yes, thank you so much, madam and sir, for giving a wonderful lecture. And thank you everyone for being a part of this webinar. Great.
Thank you, Umayal madam. Thank you, Jaya madam.
Thank you, Umayal. Thank you, Radha Lakshmi.
Session will be uploaded in the YouTube.
Actually, chairperson's voting starts from August 16th onwards. 10 days
16th
Yes.
onwards.
So I request all the presidents, chairpersons to vote all 5 of us from 16th to 25th. And Chandrapanna Swami madam in the month of September.
Okay.
Sure.
That time you will
Okay,
be
ma'am.
chairperson.
Thank you, madam. Thank you. Thank you. Thank you for taking me.
Thank you. Thank you so much.
Thank you. Sujit, do you want to say anything?
That was excellent. Excellent talk by
Thank you, Shweta. Thank you, Vijaya. Thank you, Umayal. And one thing I have to ask: have you got the nomination receipt? Anything like that from the office?
We got a acknowledgement on the consent that we have received the consent.
Yeah, we received an acknowledgement. Yes.
You got acknowledgement.
Acknowledgement that your application has been received.
That we have
been received.
They have
Vijaya, what
acknowledged
about
that they
you?
have received.
Yeah, I got it. I got it.
You, sir?
I have not yet.
Actually, I didn't send one certificate degree. So they asked me, I sent it again and they said okay.
What about Sujit?
Yeah, acknowledgement is done. If anything is required, we will connect to you.
Okay. Myself, I have to check. I have not yet got.
It might have gone
Ma'am,
in
they have
spam.
written
It
in
might
the
have gone in
mail
spam.
that within 2 days you check the spam. Plus, they've written in within 2 days you ask them if you don't get. So you ask them tomorrow.
Okay. 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 Thank you.
Thank you.
Okay, ma'am.
All the
Bye,
best.
ma'am.
Good night.
Bye.
Best of luck,
Okay, bye.
everybody.
Bye, bye.
Bye. Thank you.
Yes, bye, bye.
All the best to all of you.
Thank you. Thank you.
Thank you.
Okay.